We are part of the Safe Haven Community Services. 2019, August was the time we set aside to bring some neurologic care and relief of neuro disease burden to Liberia. And we chose the theme of epilepsy because there is a great disease burden in Liberia. Liberia is in the west coast of Africa, tropical region. We have an epilepsy belt here, which encompasses northern Grand-Bassa County, southern Nemba, eastern Bon County, and western Grangeda County. Liberia has 15 counties. It is estimated that there are 100,000 epilepsy patients in Liberia. Dr. Gaju Sek in 1983 made an epidemiological study and found that there's an epilepsy cluster and colony in Liberia, in the belt. It was on that initiative that we began to contribute and do what we could to help bring awareness to epilepsy, treatment, diagnosis, and management. The members of the team are Janet Zumo, who financed the whole mission, Malika Zumo, who was the trainee technician, Martina Zumo, who was the nurse trainer in Liberia, Tomatilo, the patient advocate. We collaborated with Dr. Jizi, the ophthalmologist, who was very gracious and helpful in streamlining the process so that we could deliver the canes to those who really needed it and providing surgical options to those who need surgery for vision care. We went to several sites, 3 counties, 7 sites altogether. We started August 12th in Grand-Bassa County, Buchanan, where we saw 125 patients in a day. Most 40% were pediatric epilepsies, 60% adult epilepsies, and of those pediatric epilepsies were about 4 or 5 of those numbers which were centered to strokes, and about 3 or 4 possible brain tumor because of the history of presentation and the semiology. It was disheartening to see that patients who are epilepsies were stigmatized and was shunned from society in this part of the world, which really it's something that is opposite to the current trend and thought and practice all around the world. We also saw that many of these patients with epilepsy did not have any social backup, no social setting. They were usually kicked out of school very early on because of the fear that epilepsy is a transmissible disease and will affect other children. So we see patients who were like 11 or 12 years old, and these patients were like in pre-K or first grade. We had patients who had several burn injuries, and that was similar throughout all the different counties that we visited. And an issue was medication supply. Many were on Tegretol, but only very short, limited, inconsistent supplies, and these patients did not have blood levels drawn to see if the hematologic side effects or liver or other such issues, which I think is very disheartening in the setting of using Tegretol in the setting of epilepsy without any drug monitoring. Then we went to Banga, Bon County, where we saw an additional 70 persons in a day. Many were epilepsy, but at least 3 or 4% were general neurological cases where we either neuropathy, lower radiculopathy, spinal stenosis, or dementia. It was a tough setting. There, the patients again reported they had inconsistent supply of medication. Medication use was Tegretol. Again, there was no blood level monitoring, no side effect monitoring as well. Bon County is about 3 hours drive from Monrovia, accessible by road easily, but most of the villages were poorly accessible. We then visited ELW Hospital, the Christian Hospital, where there was a better organization, and we were able to see 110 patients altogether, approximately, over a 2-day period, and we saw many pediatric epilepsies, adult epilepsies, and we saw a lot of other cases that were all in the general neurological setting, but interestingly, we saw people with Barber syndrome, most likely a myasthenia gravis variant that was not on steroids, but used other physical maneuvers to ensure he was breathing. We saw patients then at JFK Hospital after a tense kind of arrangement situation, which didn't go too well, but eventually we saw about 15 patients out of 60 that were scheduled, were not scheduled properly. We did give a lecture on meningitis, a main driver of epilepsy in the tropics at JFK. I gave a lecture again following day at the other area of epilepsy, the syndromes, management, diagnosis, the family medicine residents, the attendings, and the guests that was in the hospital, which I think were all well received. We then moved to the church in Cinco as a community outreach to see epilepsy patients along with the ophthalmologist. And we saw, I think, about 80 or so patients at that location. It was all well received. Each site had on its roster 2 or 3 videos about epilepsy, first in epilepsy, and what to do when you have epilepsy. These were done, and we fill up questions. We help educate, avoid, and decrease the stigmatization, and empower the patients to know about the disease and to know what options they have in terms of what's the way forward, and they should be part of normal usual society. We imparted that knowledge upon them. We were well received. They wanted to, at all sites, they asked about how could we provide more medications, and so the mechanism this was that we give a 1 or 2 month supply, and then we would refer them to the general hospital if they had the medications. If not, do how what is locally available. We then went over to NICU Town, where we saw about 20 epilepsy patients and 72 automotive patients. We went with the I team. They separated the seats, so the patient we saw ours, and that it was a very rewarding experience. We were happy to see and treat patients. We had a patient who came from the farthest county in this country, Harper, Maryland, came by boat, made a 36 hours journey, paid his fees, and was able to see us, and we gave him medication for epilepsy and gave us some clinical advice. We were able to read the neuroimaging of a few patients because they had done imaging at the site, but it was just basically given to them, and the reports were being prepared, so we really helped a few of the patients by reading the images and seeing what they were here in the hospital. And then we went to Sia, in a rural area, where we treated patients with wounds, with dementia, and epilepsy. We saw a local ongoing project which was meant to create local currency for the population involved. Overall, the clinic, this was a challenging but rewarding experience. We saw many epilepsy syndromes and other neural cases that we did not see usually in the West. The team included as well, we have a very able and capable driver, Augustine Tama, who was very helpful in navigating all the routes. Then we had Samson Davis, the videographer, who was all throughout. Our first site was Buchanan, Grand Bassa County, where we saw a total of 125 patients. About 40-50 of these were pediatric patients, and the rest were adults. All of these suffered epilepsies of different types and forms. The pediatric patients, about 4 had seizures because of pediatric strokes. 2 may have had a brain tumor because of the localizing sign on the clinical examination. We were very shocked and saddened by the degree of stigmatization of patients with epilepsy, which should not be in this day and age. We spent considerable time taking questions from the audience, and there were several who tearfully were mentioning how they were excluded from society, from school, from socializing with others, because there's a general prevalent feeling here that epilepsy is contagious. They can be nothing further from the truth. There are these people who were terribly ostracized. And this showed that there's a great need for epilepsy education, patient advocacy, treatment, diagnosis and follow-up of these patients. Several patients clearly stated the loner correlation with their disease presentation. That when the moon was full moon and up, many had seizures, and waned as the month as that ended. There were several kids with post-traumatic epilepsies, falls, and injuries otherwise during, like riding the unprotected means of travel called the bike, which is locally called pen, and the motorbikes. We treated these patients, we diagnosed them, examined and diagnosed them, and gave them medications ranging from topiramate, valproic acid, and Keppra. We began the sessions there in Buchanan and at 5 other sites where we visited during this medical mission with 2 basic videos. One, the first aid in seizure, how to recognize seizure. What are the things to do for these patients so that to protect them while they don't have these seizures? And basic awareness. We showed another video which basically detailed a little bit more about seizure presentation, the types, and what to do. And we fielded many questions and are very appreciative of this effort. The saddest part was that beyond the 30-day supply of medication which we gave them free, which were provided out of our own expense, with no external backing, they were worried that there would be no follow-up medications, which is clearly a critical problem that we have to address. We will not say much more about the supply chain of medications for anti-epileptics because we are told that any such discussions and description will be going to the political foray, which we are essentially prevented from doing. So the medication supply, I could say, short supply patients were apprehensive that there will be no further after the 30-day supply. The preventive medication that was given by some of the patients were lucky enough to be on seizure medication was carbamazepine. But sadly, these were available on ad hoc basis, and patients did not have blood levels drawn to see the side effects and therapeutic drug ranges. So this is an essential issue that is existing in epilepsy and many other diseases because basic routine chemistries, CBCs, we were told were not available, or just basically a clinical intuition or so that patients were treated. While we're en route to Buchanan, which is about 90 miles from the capital city of Monrovia, we were told there was a patient who was in status epilepticus. We're an hour and a half away. They had no medications, and the hospitals basically have no such medications. And before we got to Buchanan, patient had died while in status epilepticus. Sadly, this really saddened our heart, but there seems to be a common scenario throughout this region. Buchanan is the capital city of Grand Bassa County, which, as Dr. Carlton Gajusek delineated in 1983 in his article in the Journal of Neuroepidemiology, that Buchanan was part of the Caesar Belt in Liberia, which includes northernmost part of Buchanan, the northern part of Grand Bassa, the southernmost part of Nemba County, eastern Bond County, and western Grand Gila County. We are yet to determine on a full scale as to what could be the inciting events, whether the genetic epilepsies, whether included of cerebral palsy, or whether because patients are clustered in these regions because the stigmatization and shaming is so severe that patients escape from town, from the village, from the cities, go to villages to die. So there we postulated that these patients live in these clusters, isolate clusters, and between episodes, try to live a normal life, including procreation, and then have patients with seizures as well, so there may be genetic transmission of these of genetic epilepsies. However, there's a high rate of tropical infection, CNS infections, and I think also poorly treated meningitis, as well as head trauma, especially post-war era. So there are many contributing factors to the presentation of epilepsy in this region. For the study, including DNA extraction analysis, with electroencephalograph and routine chemistries in this study will be very helpful, as well as computer tomography, which is absent in this part of Liberia. As a matter of fact, Liberia has only, as far as I know, 3 CAT scans throughout the whole region, right, in the whole country. Buchanan has none. That was the experience of the first medical mission visit, the Buchanan, which was on August 12. We saw 125 patients. We had 2 teams. We had a Buchanan team and a Monrovia team that assisted us in triaging the patient, registering them, and examination, and nutritional records, medication, registration, all of that, all of those things, which made the mission possible and successful. Then we went to a Phoebe hospital in Banga, Bond County, where there were some communication delays, but we were able to see 68 patients, 70 patients, several with epilepsy. About half, 40% of the patients were peds, and 60% adults. A few children had stroke as onset of, as an etiologic agent for the onset of their epilepsy. And others were genetic and other CNS infections that we presumed were based on the clinical examination. We had the night before visited Banga, because it's 3 hours away from the capital city, about 130 miles away. So we had to go the night before to situate ourselves and see patients early the next morning, and then be able to leave there and go back to Monrovia the same day. There were some difficulties in lodging. We, however, used our senses and field experiences to be able to secure lodging and be able to prepare for the patients for the following day. The registration at that site was a little chaotic, but thanks to the very competent staff, we were able to get up to 70 patients on that day, and a few included were patients with strokes, Parkinson's disease, and other general neurology cases. Again, we showed the 2 videos, first aid in seizures, and what to do when the patient has seizure. So give some background and education. We answer the questions of the patients, which were very astute in many cases, as they were aware of the disease, but because they were stigmatized, they were clustered away. We were given the opportunity to ask questions and answer their questions. They were very forthright, forthcoming, and had very deep questions about the disease, the nature of the disease, and prognosis. On August 17, 18, we were guests of the ELW hospital in Monrovia, where we saw a total of 101 patients over the 2-day period. About 40% peds, 60% adult again. We were able to diagnose patients, about 3 or 4 patients with pediatric stroke as a consequence of their seizures, and about 3 or 4 with possible brain tumor based on the clinical examination. We were able to recommend a CT scan for several of these patients who critically needed it because of the shortage of CT scans and the financial cost associated with it will become very prohibitive for many patients. Dr. Sikra, head of ELW Hospital, was very gracious to allow us to use their facility for these examinations, recommended the patients who had the great need for CT scans. It was done pro bono at the goodwill of ELW Hospital and Dr. Secrets. We thank them, and we thank them, as well as the administrator, John
who we spoke with briefly during different parts of those days. It was very well organized at ELW Hospital. We had a dry run a day or two before the patients were seen, although despite all of those, we still had chaotic first day, but they all smoothed out and everything went smoothly. At ELW, we saw very patients. Among the peds, we saw several manifestations of cerebral palsy. We diagnosed a patient with tuberous sclerosis. They are autosomal dominant form, most presumably. There were some general neurological cases among the adults. Interestingly, there's a patient, 60-year-old gentleman with bulbar symptoms, biocular palsies, nasal speech, and difficulty breathing at times, which suggested of myasthenic syndrome presentation, whether it was ocular with slow bubble progression. This gentleman was very unique that in the absence of O2 and absence of steroid, he began to use toothpicks in his teeth so as to stimulate his oral cavity and the oral nasal cavity to maintain breathing, which was, I think, a dramatic presentation of self-preservation in patients who have no access to care. That was on the 17-18. On the 19th, our team visited John F. Kennedy Hospital, the main teaching referral hospital in Monrovia, where I gave a lecture on staphylococcus meningitis, its manifestation, pathophysiology, presentation, epidemiology, as well as vaccine presentation. I fielded a lot of questions from different attendings and the medical students and the residents. It was a very lively 1-hour discussion. It was mutually beneficial. From their own assessment, we then discussed essentially to the meningitis belt, which was essentially an aspect that needed to be covered because the local infrastructure, the lack of rapid CSF analysis, and delays in treatment, which can provide suboptimal recovery in patients with meningitis. We visited then the Jamali clinic, where we asked about the MRIs and CAT scans and different fees. We got a broad view of things, and a few patients were later referred to that. We are not sure because we have no follow-up yet on these patients. The same day, the 19th, we had JFK give a lecture. We were told that there would be cases that we will see. There were conflicting numbers, 60 or 15 or so. Eventually, after much administrative changes or wrangling, we were able to see 15 patients. The broad general neurological cases, many with neuropathies, non-radiculopathies, and stroke. We saw a young gentleman about 70 years old who had a post-traumatic spinal injury with total lack of bowel control. He has no access to Detrol or Ditropen because of a severe lack of medication in this country. We referred him to have a static MRI of the lumbar spine and to see neurosurgeon as possible to see how some of these deficits will be corrected. On the 20th, we visited the Breath of Life Adventist Church in the Central O Road, where we saw about 70 to 75 patients, peds, adult epilepsy and general neurology, and these patients, we had spent a full day, 8 to about 3 p.m. And parallel to us here, Dr. Gizi, the local ophthalmologist, local eye institute here, joined us. Simultaneously worked. They were examining eye patients with eye disease, and with the epilepsy of the patient, and they work very smoothly. And they have well-established routine of follow-up, and the patients will be followed up at the District Hospital, separate autonomous institute of eye medicine, basically. The other patients we saw, who had epilepsy and needed for the workup, were referred to ELW Hospital. We visited other sites and patients that we saw at different places to be able to educate and treat and give prognostication of their diseases. And there are several such interactions, including in Newtown, where there was a lot of patients with epilepsy with the same lack of resources, lack of advocacy, lack of finance, lack of medication, and all the lacks that we can think of.
The cane distribution was very, very well received because many patients had no means of ambulating and rely on other people to move them around, and the cane promises to give them some viability and mobility so that they can be more independent. Overall, it was, I think, a positive mission. We summarized our strengths and our weaknesses and how we do better for the future. And I think we did make an impact for the people of Liberia suffering from epilepsy and other neurological diseases. Thank you.